صباح الخير. The topic of my presentation today will be Introduction to Maxillofacial Prosthesis. Maxillofacial Prosthesis is a branch of prosthodontics concerned with the restoration and or replacement of intraoral and associated facial structures. A maxillofacial prosthesis is any prosthesis used to replace part or all of the stomatognathic and or craniofacial structures. زي ما انتوا عارفين stomatognathic stomato denotes oral cavity in Latin language and gnathic means jaws. So stomatognathic means anything replacing part of the oral cavity or the jaws. Craniofacial part of the cranium and the face. Therefore, a maxillofacial prosthesis will replace any part of the stomatognathic and or craniofacial structures. This is an appliance made for a case with cleft palate or with a case of acquired defect after tumor resection, and extraoral prosthesis like the replacement of the whole or part of the nose as well as the ear. A maxillary defect denotes disruption in the continuity of the normal oronasal partition. بمعنى ان احنا هنعرف بعد كده ان الاورال cavity is separated from the nasal cavity by a partition which is the hard and soft palate. They are connected only in the most posterior end. Any disruption in this partition we call it a maxillary defect. However, a cleft is a gap or a split between two things. That's to say, a cleft is applied only to congenital cases because we have the two parts of the palate with a split in between, so both parts are similar to each other. However, we cannot apply the word cleft to acquired cases زي ما هنعرف بعد كده. Types of maxillofacial defects. Maxillofacial defects are divided into three main types: congenital defects, acquired defects, developmental defects. Congenital defects, these defects are present since birth. Acquired defects, those defects are acquired after birth. So the child is born normally, however he gets a defect later on, so we call it acquired defect. Classification of maxillofacial appliances. We divide maxillofacial appliances into four main types: into intraoral appliances, extraoral appliances, combined intraoral and extraoral appliances, as well as cranial and facial restorations. Intraoral appliances. These include obturators, which are used to close a congenital or an acquired defect in the palate, stents, which may be used to control bleeding, to promote healing, as a vehicle for radiation therapy, or to hold grafts in position, splints, are used to hold fragments together in cases of fractures until healing takes place. Resection appliances, which are used in cases of mandibular defects to correct the path of closure of the mandible. All these appliances will be discussed in details along the course. Extraoral appliances include radium shield, which are used for protection from radiation, restoration of missing eye, missing nose, missing ear by eye prosthesis, nose prosthesis, or ear prosthesis. Earplugs, which are used as hearing aids. All these are extraoral appliances. Combined intraoral and extraoral appliances, those are used in cases where there is a lost part of the maxilla or the mandible together with the facial structure. So we have a combination between two types of prosthesis, an intraoral one and an extraoral one. Therefore, we call these appliances combined intraoral and extraoral appliances. Cranial and facial restorations include two types: cranial onlays and inlays, which are used to compensate for lost cranial bones due to skull injury, or extraoral implants, which are used for holding an extraoral prosthesis. Maxillofacial team. A team can be defined as a group of people working together to achieve a certain purpose. The management of patients with acquired or congenital defects require a multidisciplinary cooperation. It involves the cooperation and coordination of care among members of a multidisciplinary medical team. That's to say, we cannot work alone in cases requiring treatment with an intraoral problem or extraoral problem, but we need a team to work together. The members required for the formation of the maxillofacial team include plastic surgeon, which play the most important role in carrying the operation, a prosthodontist, which will be able to restore the case after treatment, an orthodontist, which plays a role in cases with cleft lip and palate, an oral surgeon, which will be needed for extraction of any teeth in the field of irradiation or extraction of a tooth before resection. A speech therapist will have a role in treatment of the case, especially in cases of congenital defects, as well as in cases of acquired defects. Otolaryngologist or an ear, nose, throat specialist will be very helpful in cases with cleft palate. Psychologist will play a role for patients with orofacial defects. Dental technician, which is the one responsible for construction of the prosthesis. I need a well-trained maxillofacial technician and not an ordinary technician. And the social worker, which will help the child and the family in dealing with the social environmental aspect of the cleft abnormality. This was a short revision of the last lecture, and the next topic will be cleft lip and palate. Normally, the nasal cavity is separated from the oral cavity by a complete partition, let's say by the maxilla and the palate, which prevent communication except at the most posterior end through a well-coordinated velopharyngeal sphincter, or we call it palatopharyngeal sphincter. Therefore, the nasal cavity is separated from the oral cavity. The connection occurs only at the most posterior end. A sphincter is present, which we call it velopharyngeal sphincter. Velo is coming from the word velum. Velum denotes soft palate. So we call it velopharyngeal sphincter or palatopharyngeal sphincter. This sphincter is responsible for either totally separating the oral cavity from the nasal cavity, or the presence of a small communication between the oral cavity and the nasal cavity according to the need. The palate is formed due to the fusion of the two palatine processes and the premaxilla. To understand congenital cases, we have to return back to the embryology. Development of the lip and alveolar process begins around the 5th weeks of intrauterine life. The primary palate is formed during the 4th to 7 weeks of intrauterine life from the median nasal process, which is developed into the premaxilla. The premaxilla is the area containing the 4 incisor teeth. The secondary palate is formed at 6 weeks of intrauterine life as a bilateral projection, emerging initially in a vertical direction. After the formation of secondary palate, the mandible will start to grow. Then the tongue will drop downwards. The dropping of the tongue will allow the two palatal shelves, which were present in a vertical position, to rotate in a horizontal position. The red part represents the tongue. The two lateral parts represent the palatine processes. After dropping of the tongue, these palatine processes change their position from vertical position to horizontal position. Then fusion occurs in the form of Y shape, starting in the center and progressing anteriorly and posteriorly, to be completed at 12 weeks of intrauterine life. A prosthodontist, which will be able to restore the case after treatment, therefore the median nasal process will be formed into the philtrum of the upper lip, and the premaxilla, which is the area including the alveolar process containing the incisor teeth. Fusion of the median nasal process and the lateral nasal processes will form the upper lip. Fusion of the premaxilla and the two palatine processes will form the hard palate, soft palate, and jugular. Instance. It varies according to the population. The highest instance is in the American Indians, 1 in every 278 live births. The smallest instance occurs in the Scandinavians, 1 every 3,000 live births. Usually, the accepted instance rate is 1 in every 1,000 live births, more common on the left side, then bilateral, and the least on the right. That's to say, when we say it is more common on the left, this denotes that the right side in most of live births occurs first in the right side. Therefore, when we have a cleft, it will be in the left side. Then bilateral, which denotes both arms are not united, or occurs on the right and the left side is intact, which is the opposite of the normal occurrence, which sometimes occurs. Males are affected twice as females. This may be due to fusion occurs in the males slightly more earlier. That's why the instance of cleft cases is in males twice as females. Factors affecting the induction of cleft palate. Cleft palate occurs either due to hereditary cause or environmental cause. Hereditary cause means in parents with deformity, their infants may be born with a cleft. Environmental causes means an interfering factor occurs during pregnancy, which at the end resulted in the formation of a cleft. This includes endocrine factors like hormonal disturbance and cortisone treatment, radiation and X-ray, especially to the pelvic region, nutritional deficiency like vitamin E deficiency and riboflavin, which is B2, infection and disease, especially German measles. In case of German measles, we have to do an intended abortion because the child will be born with multiple deformities. Stress and disturbance of fetal circulation result in reduction in the blood supply to the embryo, which will end in lack of fusion of the palatal processes, resulting in the formation of a cleft. And lastly, chemical irritation like hypoxia or hypervitaminosis A. That's to say, hypovitaminosis A and hypervitaminosis A may result in the formation of cleft. Classification of cleft lip and palate. Generally, there are three types of clefts: a cleft lip without a cleft palate, a cleft palate without a cleft lip, or a cleft lip and palate together. In addition, clefts can occur on one side, and we call it unilateral clefts, or on both sides of the mouth, and we call it bilateral clefts. This is a general classification. The second classification, which is provided by Boomer et al. In the International Confederation of Plastic and Reconstructive Surgery, and we call it International Confederation of Plastic and Reconstructive Surgery classification. This system prefers a simpler classification based upon embryology. It includes three categories: cleft lip and alveolus, that's to say the cleft occurring in the area of the primary palate; cleft of the hard and soft palate, that's to say cleft is occurring in the area of the secondary palate, or a combination of the previous two, that's to say combination of cleft in the primary and secondary palates, which may be either unilateral or bilateral. Another common classification, we call it Voss classification. Voss classification is divided into four types. Type 1 Booth classification divided cleft palate cases into 4 types. Type 1 denotes cleft of the soft palate only. Type 2 denotes cleft of the hard and soft palates. Type 3 denotes cleft of the hard and soft palates together with unilateral cleft in the alveolar ridge and the upper lip. And type 4 denotes cleft of both the hard and soft palates as well as bilateral cleft in the upper alveolar ridges and the upper lip. Another classification is provided by Kernahan and Stark, and we call it Kernahan and Stark symbolic classification. That's to say, they require symbols to describe the cleft case. So they divided the Y configuration into 9 areas. Areas 1 and 4 denote the lip. 1 is for the right side, 4 is for the left side. Areas 2 and 5 denotes a cleft in the alveolus, 2 for the right side and 5 for the left side. Areas 3 and 6 denotes cleft in the palatal area between the alveolus and the incisive foramen, and also 3 is for the right side, 6 is for the left side. Areas 7 and 8 denote a cleft in the hard palate, and area 9 denotes a cleft in the soft palate. As you see in this diagram, 1 and 4 is for the lip, 2 and 5 the alveolus, 3 and 6 the rest of the Y shape, 7 and 8 for the hard palate, and 9 for the soft palate. Disabilities. Disability of a patient with cleft tibia and palate includes improper feeding, improper swallowing, aesthetics, general health, psychological trauma, as well as problems in speech. Regarding the speech mechanism, in short, the main muscle in the soft palate which shares in the action of speech is the levator villi palatini muscle. We will discuss this part in details in the next lecture. The levator villi palatini muscle will draw the soft palate upward and backwards, causing its free margin to contact the posterior pharyngeal wall. This occurs during swallowing and oral breathing. During speech, also, the pharynx contracts and causes an inward movement of its lateral and posterior walls to form the palatopharyngeal sphincter. Therefore, movement in the soft palate as well as contraction of the lateral and pharyngeal walls will result in the formation of the palatopharyngeal sphincter, which separates the oral cavity from the nasal cavity. Therefore, a patient with a cleft will suffer problems in feeding, breathing, speech, dental problems, as well as infections. Treatment. We divide the treatment into 3 phases: pre-surgical phase, surgical phase, and prosthetic phase. Pre-surgical phase starts at birth and may continue up to 3 months till the surgery is performed. It includes 2 parts: early intervention and counseling with the parents, as well as management of the problem of feeding. Early intervention and counseling. When an infant is born with a cleft, the cleft palate team will help in assessment of the severity of the case, reassurance of the parents, teaching the parents how to deal with the cleft problems. Regarding the feeding problem, maintaining nutrition is necessary for growth and development. Therefore, proper feeding will help in infants' preparation for the first surgery. Thus, depending on the severity and the type of the cleft, a variety of feeding devices are available. How to manage this case? In infants with isolated cleft lip, they often feed normally or use a broad-based nipple, which will help in proper feeding without any help of an appliance. However, in cleft palate cases, the case is more complicated. Whether it is combined with cleft lip or not, the feeding problem will be more significant as they cannot generate a negative pressure during suckling. They cannot create a negative pressure to properly feed from the feeding bottle. Why they don't have a negative pressure? Because there is a communication between the oral cavity and the nasal cavity. There are certain guidelines may be helpful until we construct a feeding appliance to help this child to feed normally. We can use a soft broad nipple adapted to the palatal defect to close the defect during feeding. Also, we can cut the nipple of the feeding bottle in cross cut, therefore it allows easy flow of milk and decreasing the strain on the child. We may use longer nipples, which are more successful as they are placed posterior to the defect, therefore the milk will be coming from the bottle behind the area of the cleft. In all cases, we have to use a squeezable plastic bottle so we can press on the bottle to provide some milk and wait for a while and then give another dose of the milk and so on. I have in all cases to put the infant in a semi-sitting position during bottle feeding. Lastly, I will construct a feeding appliance to help this child to feed normally. Surgical treatment. For the lip, it's usually performed at around 3 months, about 10 to 12 weeks, in order to facilitate feeding and improve the appearance of the child. Lip repair should be carried out without excessive tension in order to help to establish a favorable contour in the premaxillary area. Also, it will help to narrow the palatal cleft if present. Therefore, lip repair is carried earlier than palatal repair. The time of surgery for cleft lip cases depend on the rule of tens. That's to say, the child should be at least 10 weeks, at least 10 pounds in weight, and the hemoglobin count should be at least 10. And this we call it the rule of tens. Combined intraoral and extraoral appliances. Those are used in cases where there is a lost part of the maxilla or the mandible together with the facial structure. So we have a combination between two types of prosthesis, an intraoral one and an extraoral one. Therefore, we call these appliances combined intraoral and extraoral appliances. The surgery on the palatal shelves should not be performed too early because as the child grows, the palatal shelves will continue to grow and the cleft will narrow. This will be helpful for the surgeon to close the palatal cleft. In addition, I have to wait to allow growth of sufficient tissues to help for proper closure of the cleft palate. The timing for palatal closure varies. If we make this surgery very early, about 9 to 18 months, we can carry this surgery with bone grafting. However, there is a negative effect on maxillary growth. That's to say, it will retard the maxillary growth if we close the palatal cleft very early, or we can delay this operation slightly to be carried out between 12 months to 4 years, depending upon the width of the cleft, to allow a time for proper maxillary growth, or we delayed the closure till we reach the stage of mixed dentition, which is preferred by most teams. This is carried out especially if the cleft is very wide, and therefore in these cases there is no sufficient tissues available for closure. Regarding the alveolar cleft, the timing for surgical closure of the alveolar cleft can be divided into 3 categories. We can do the alveolar cleft very early. That's to say, we close this oroantral fistula with or without the placement of bone graft at the time of lip closure. That's to say, we carry this operation before 1 year with the time of lip closure, or we delay this surgery to do a secondary closure. That's to say, you close the lip alone and delay the closure of the alveolar cleft for some time. This is applied for those patients who have a fistula that should be closed and bone grafting of the alveolar cleft is required, and we wait till the mixed dentition stage. Or we use a delayed closure, which applied to those patients having their alveolar cleft grafted after their growth is completed, and we graft the area of the cleft in order to be able to place dental implants. This commonly occurs in the area of the lateral incisor, and in order to place an implant in this region, we have to graft first the area of the alveolar cleft. Prosthetic treatment, which is the third phase, is divided into 2 main phases: in infants and in adults. In infants, we have 4 appliances: feeding device, nasoalveolar molding device or NAM, expansion type prosthesis, and interim speech aid prosthesis. In adults, we have 3 appliances. 2 of them are considered history, and they are not carried out nowadays, and the third one is the one we do, which is called the fixed pharyngeal obturator or speech aid prosthesis, while the mobile prosthesis or the meatus obturator are only a history for appliances made for these cases. Feeding device: when we have a patient with a cleft palate, I have to take an impression. It's very difficult to find a tray for this child, so we use a teaspoon, and we use the back of the teaspoon to take the impression. We usually use impression compound. During impression making, I have to remove the impression before hardening and replace it again and remold it. The most important point in using the impression compound is that we can correct small errors in the borders after making the impression. If we have major errors, I can make a special tray and take the impression with medium body rubber base in a second phase. Or if I have the impression accepted, so I can construct directly the feeding appliance from this impression. As you see here, we used the handle of a metal stock tray as a tray to make the impression, and then we made an acrylic special tray, and we took the impression with medial body rubber base. In the feeding appliance, we make a metal wire as a handle. The most important part is where to place the metal wire. Do we place it on the left side, or in the middle, or on the right side? When you think in this point, you will find that the wire is always placed on the left side for right-handed mother. Therefore, she is able to place the feeding appliance very easily. However, in left-handed mothers, I have to modify the position of the wire to the right side, because the mother places the head of her child on her right hand, and therefore when the handle is on the right, it will be very easy to be placed. We do not make the wire handle in the middle because it would interfere with the placement of the feeding appliance. The second type of appliance, we call it mesoalveolar molding device. This may be done to realign the lateral segments to prepare them for surgical closure with or without bone grafting. It realigns the lateral palatal segments before surgical closure. This appliance is very helpful because it will reduce the size of the intraoral alveolar cleft before surgical closure. Also, it will mold and position the surrounding soft tissues in the cleft nose. Third, it will help the tissue expansion in the area of the columella, which is the lower part of the nasal septum, before surgical closure. In case of bilateral clefts, we use this appliance for 5 to 6 months to complete the molding. In unilateral clefts, 2 or 3 months are enough. How to construct? The appliance is constructed from acrylic resin. We make a relief in the fitting surface and we apply a tissue conditioner, and we make a slit in the anterior part only from the middle to allow the approximation of the palatal clefts. Then we align this appliance with tissue conditioning material. As you see, it's a different color. The pink color is the tissue conditioning material. In order to allow molding, we use elastics, orthodontic elastics, and we use adhesive tape. The best adhesive tape to be used is the stair strips. Stair strips are used for closure of minor wounds, and they adhere very easily to the skin. I connect the orthodontic elastic to the stair strip and fix the stair strip on the lateral side of the face and adhere it with adhesive tape. بمعنى هندخل الاستيك طرف الستير ستريبس، هندخل طرفه جوه الاستيك ونتنيه ونثبته، يبقى اصبح عندنا الاستيك كده ثابت في الستير ستريب كويس. نعمل واحد للناحيه التانيه ونحطه بحيث ان الاستيك يبقى عند اول اللب، علشان اما نبتدي نشده يقرب التو سيجمنتس كويس. بنخاف اما نشد ان الستير ستريبس تطلع من الوش، فنستعمل ترانسبيرنت ادهيسيف تيب ونثبته على الفيس. طب ايه الجزء التاني بقى اللي طالع من الواير؟ الجزء ده بيطلع من الابلاينس يدخل جوه النوسترل عشان يساعد الفورميشن اوف ذا راوندد فورم اوف ذا نوسترل. لو انا عندي يونيلاترال كليفت هيبقى عندي دراع واحد بس وبينتهي ب سمول اكريليك بارت. لو انا عندي بايلاترال كليفت يبقى هيبقى عندي دراعين. لو يونيلاترال كليفت هنطلع اكريليك ارم طالع من الابلاينس واحد بس، زي ما انتم شايفين في الصوره اللي على الشمال في ارم واحد ونشد الاستيكين فيه. طب لو عندي بايلاترال كليفت يبقى هيبقى عندي 2 نيزل اكستنشن و2 اكريليك باتونز. اما اجي اركب الالاستيك هاخد الاستيك اليمين اركبه في الباطن الشمال وهاخد الاستك الشمال اركبه في البطن اليمين. زي ما انتم شايفين ادي الابلاينس وادي الاكريليك باتون، بس هنا اللي حط الالاستكس حطهم غلط، حط اليمين في اليمين والشمال في الشمال. ده كده هيوسع البالاتال سيجمنتس مش يقربهم. انا عشان اقرب السيجمنتس يبقى هعمل ايه؟ هاخد الاستك الشمال اركبه في البطن اليمين، والاستك اليمين هيركب في البطن الشمال. ده شكل الحالة قبل المولدنج على الشمال، وبعد المولدنج اتحسن شكل النوسترلز جدا، والبريماكزيلا نزلت لوضعها، وساعتها السيرجري اما تتعمل هتطلع very good aesthetics for this child. دي حالة تانية برضو عنده bilateral clefts، خدنا له impression الابلاينس. تالت نوع من الابلاينسز هو الاكسبانشن تايب prosthesis. This may be done to expand the collapsed clefts and the jaw growth and dento-alveolar development do not follow the normal growth pattern in children with cleft. Why? Because we have intrinsic tissue deficiency، بمعنى التيشوز اللي عندنا قليلة ان احنا نقفلها surgically or early or improper surgical treatment. يعني ايه الكلام ده؟ يعني مش شرط ان الحالة يكون الكليفت ما اتقفلش، ممكن اتقفل بدري ادى الى حدوث ماكسيليا كولابس، فهحتاج ان انا ارجع السيجمنتس دي لمكانها. هنستخدم ساعتها برضو الاكسبانشن تايب بروسيسز. احيانا كمان الانتيريو الفر بروسيس بيحصل له ناروينج، وبيحصل ناروينج ماكسيلي ارش، وتلاقي البري ماكسيلا نازله لتحت، فساعتها انت مش عارف ترجعها مكانها. محتاج الاكسبانشن تايب بروسيس ده يساعدك يرجع البروبر بوزيشن تاني. ممكن كمان ان لو الليب كلوجر اتعمل اندر تنشن، البريشر ده هيزق لي البري ماكسيلا لتحت. ممكن كمان يبقى عندي سكار تيشو من البالاتال ريبير فبيعوق الماكسيلي جروس. كل الحاجات دي بتخليني الاقي عندي كولابسد ماكسيلا. كولابسد ماكسيلا الابلاينس اللي هنستخدمه معاها هو الاكسبانشن تايب بروسيس. كل الحاجات دي هتؤدي لايه؟ This may result in malalignment of teeth and thus requires the expansion of the maxilla to correct the palatal segments in proper position and correct the crossbite. We use a palatal expansion type prosthesis which is done at the age of 7 years when the permanent incisors and first molars are erupted. طب ليه؟ لأن أنا مش هقدر أحط كلاسب على الإي. الإي is very weak. لو حاولت تعمل اكسبانشن على الإي هتلاقي الإي ده بقى very loose. بنستنى الفيرست مولر يطلع وبعدين نعمل الأبلاينس ده. ساعتها أقدر تو أبلاي يا إما ميتال باند أورثودونتيك ميتال باندز، يا إما أستعمل الكلاسبس. في الحالتين الفيرست مولر يستحمل البريشر وأقدر إن أنا تو أبلاي الأبلاينس ده مظبوط. These appliances will expand the collapsed cleft and properly align the lateral segments to prepare them for surgical closure with or without bone grafting. It consists of two separate lateral sections united by an expansion device and covering the hard palate, and we gradually open the expansion device to realign the lateral segments. I have to monitor the eruption of teeth as they do not follow a normal pattern. Therefore, any tooth erupted, I can relieve the appliance from its place to allow its proper eruption. A decision is made whether to leave the missing lateral space opened or not، بمعنى ان انا بيبقى مكان الكليفت lateral incisor missing، ممكن الاورثودونتست يقفل السبيس بتاعه والكناين نشيل التيب بتاعته ونحوله lateral incisors، او ممكن نسيبه later on نحط implant وتحط عليه كراون. على حسب الويدث اوف ذا ارش بناخد قرار هنعمل ايه. Regarding the feeding problem, maintaining nutrition is necessary for growth and development. Therefore, proper feeding will help in infants preparation. آخر appliance بيتعمل للinfants هو الانترم speech aid prosthesis. This may be done to restore the palatopharyngeal function during childhood or for patients with hypernasality following surgical procedures. بمعنى لو أنا عندي ولد صغير وجود الكليفت هيخلي الكلام يطلع فيه hypernasality. hypernasality denotes excessive air emission from the nose، فالكلام ما بيطلعش واضح، بيطلع مخنف شوية. فلو هو كان عمل palatal surgery وبعد السيرجري ما عندوش proper separation بين oral cavity والنيزل cavity، هيبقى بيشتكي من ايه؟ هيشتكي من الهايبرنازاليتي. الابلاينس ده هيقفل له السمول ديفكت اللي في البوستيريور اند علشان يقفل السبيس اللي فاضل بين الريمينينج سوفت بالاتال تيشوز والفارنجيال وول، فيمنع الهايبرنازاليتي. او هو ما عملش سيرجري خالص، ففي الحاله دي انت عامل ابلاينس هيقفل البالاتال كليفت وهيقفل كمان لغايه البوستيريور فارنجيال وول. طب ليه بنعمله؟ لان احنا مش هنقدر نعمل الديفينيتيف تريتمنت قبل 17 سنه. السكيلتون فريم ورك ما بنعملوش قبل 17 سنه علشان لو اتعمل بدري بيعوق اللاترال ماكسيلاري جروس. ففي الفتره دي مش معقول هتسيب الولد ده عنده هايبرنازاليتي، هنضطر ان احنا نستخدم الانترم سبيتش ايد لغايه ما يوصل للبروبر ايج. احيانا كمان الانتيريو الفر بروسيس بيحصل له ناروينج، وبيحصل ناروينج ماكسيلاري ارش، وتلاقي البري ماكسيلا نازله لتحت، فساعتها انت مش عارف ترجعها مكانها. محتاج الاكسبانشن تايب بروسيس ده يساعدك يرجع البروبر بوزيشن تاني. ممكن كمان ان the prosthesis will restore the velopharyngeal functions very effectively and is well tolerated by the patient. It needs to be removed periodically to account for growth and eruption of the permanent dentation. بمعنى ان هو هنقول له ما يلبسوش طول الوقت، يلبسه ما يبقى هيتكلم بيه بس علشان يسمح بلاترال ماكسيلاري جروس. هو ما بيلبسه هتلاقي الكلام طالع نيلي نورمال، مفيش هايبرنازاليتي. الثانيه في الابلاينس ده ان انا مش لازم اعمله مره واحده، انا ممكن اعمل البالاتال بارت واعمل الفيلر بارت اللي هو جاي على السوفت بالات، هيفضل لي الجزء اللي ورا خالص اللي هو الفرنجيال بارت اللي واصل لغايه اللاترال فرنجيال وول اعمله بعد ما يتعود عليه. يعني هسيبه اسبوع او 10 ايام لابس الابلاينس، صحيح الكلام ما اتحسنش لكن قدر يتعود عليه. بعدين اما نزود الفرنجيال بارت الجزء الاخير اللي هيوصل لغايه البوستيريور فرنجيال وول نعمل له مولدنج بكومباوند. هنعرف ازاي بعد كده في الديفنتيف بروسيسز الجزء ده ازاي بيتعمل وازاي بيتعمل له بروبر مولدنج، وهنقدر ان احنا نزوده على الابلاينس بعد كده لما يكون اتعود على الجزء الاولاني وتعمل له الجزء الاخير فيقدر يلبسه. لكن لو عملناه واصل لغايه البوستيريور فرنجيال وول من الاول هيبقى الادابتيشن تو ذيس ابلاينس از فيري ديفيكولت. ممكن نعمله ماسك بادم كلاسبس، ممكن نعمله ماسك بسي كلاسبس، وهنزود الجزء الاخير بكومباوند وبعدين نحوله انتو كلير اكليريك ريزن. ده معمول اهو بسي كلاسبس، اللي فات كان بادم كلاسبس. الجزء الاولاني اللي هو البالاتال بارت جاي على الهارد بالات، الجزء الرفيع ده اللي هو معدي فوق السوفت بالات، والراوند بارت اللي في الاخر هو ده اللي واصل لغايه البوستيريور فرنجيال وول، اللي بيبتدي البوستيريور لاترال فرنجيال وول يقفلوا عليه عشان يفصلوا لي الاورال كافيتي من النيزل كافيتي ويضيعوا الهايبر نازاليتي. ثانك يو.